your experience about telemedicine. If you have got some experience about telemedicine and some knowledge about rules and regulations in other countries also, that would enlighten us and each other so that we can justify our activities in a better way. So, friends, incorporating telemedicine into healthcare practices is the discussion today. Next, please. In the light of corona epidemic or COVID-19 epidemic, we have advised, we have been advising people that don't rush to a clinic or a hospital or to your doctor, because if you are having that infection, you will spread to the community, and maybe that somebody else at the hospital or the clinic is having that infection. You might catch the infection. So it's better to call the doctor on phone or any other way and take his advice. But for that, we need to have some legal ground, and let us discuss all the legalities and all the details. The goal of this webinar is to orient doctors to the field of telemedicine so that they can effectively use telemedicine in their day-to-day practice in light of corona epidemic, and develop an insight so that they can use it in future, as Board of Governors of Medical Council of India has visualized. Next, please. Yes, and the objectives are by and large narrated by Srestha, that we will define telemedicine, tell pros and cons of telemedicine, classify telemedicine in context of response time, media used, and initiator of the call, the advantages and disadvantages of all of above, the process of consent, the legal liabilities of the doctors, and tell what services can be offered by telemedicine, the different classes of drugs according to new guidelines. Now, with the classes, I don't refer to the classes like antibiotics or this or that, NSAIDs, but the classes which are defined in the new regulation. Tell what types of drugs can be used in which situation. Again, not suggesting the standard treatment guidelines, but the situation of telemedicine, not situation of the patient. Which drugs can be used in which situation of telemedicine. Have first-hand experience of IO platform. We have got such a telemedicine platform with us, and we will have some first-hand experience of that. Tell involvement of different branches of medical field in telemedicine and what advancements are available. Next, please. With the corona epidemic, we started advising telemedicine, but who has not experienced this? Somebody might ring you up and say, doctor, remember me? I am Ramesh, and I attended your clinic yesterday for fever, and you had advised some blood tests which were negative. Now, the problem is that what should I eat? Now, you may say that when I see so many patients and I cannot remember and cannot advise like that. So he says, okay, it doesn't matter. I'll send you my investigation reports, and please advise me in the light of that. I may send you the prescription also. Or somebody might have some more personal approach, saying that, uncle, I am Suresh, I'm speaking. Remember me, I am son of Madhav Singh ji. Uncle, my father has fever and is coughing too. Can I give him that cough syrup what you had prescribed it to me? And can I give paracetamol for his fever? Sometimes you oblige and sometimes you don't. Sometimes you might say that, well, I need to examine the patient and I cannot say like that. Or maybe that sometimes somebody will say that, okay, my father is very old. Last time I had brought him here. And with your medicine, he is better. Now, please tell me whether should we continue the medicine or reduce the dose or what. In the meantime, welcome Gilbert, and we look forward to your participation. And at the end of the session, you will please enlighten us about the regulations in US and kind of activities going on there. So we all have experienced such kind of telemedicine activities. Next, please. And changes the way of life. See, an old person like me, who has put in some 4 decades of clinical practice, and before that I was studying, and in those days we were taught interpersonal relationship and doctor-patient relationships, and these were major focus areas. But the change is the way of life. Darwin also has said that adaptability is the key for species to run along. So we need to adapt to the change. We need to take up the challenge of the change. And the change today is telemedicine. Next, please. Yes, Dr. Raja Sekhara, welcome. Very recently, it so happened that Board of Governors, Medical Council of India, Srestha, can you address to? Yes. Board of Governors published some guidelines regarding telemedicine. They are in force today. And they have published this guideline because we have been advising people to take up telemedicine, to resort to telemedicine. And on the other hand, we didn't have legal ground for it. In fact, Mumbai High Court, before only 2 years or so, had given a verdict which was against telemedicine. Now tell me, who will practice telemedicine? Even if you want to, you will not, because you don't want to do anything against the law. And that's why we needed some legal ground, and Medical Council of India giving some regulations and Government of India publishing it becomes that ground so that we start practicing it. But the Medical Council of India has gone a step ahead, that they have suggested that all registered doctors under Medical Council of India Act 1956, that is MBBS and above, will have to clear an online program developed by Board of Directors in coming 3 years. Within 3 years, you will have to clear a program or a course, and then you will be in a position to practice indefinitely the telemedicine. And for the new registrars, that is people passing now, will have to complete the course even before they ask for registration. That's during internship. They have also agreed that there is some ambiguity. As I said, that Mumbai High Court had given such verdict. So now these guidelines give legitimacy for telemedicine by the use of qualified doctors. The way Medical Council of India has given guidelines, there are other systems of medicine prevalent in India, and major systems are homeopathy and Ayurveda, and they have got their own respective councils. These councils also have given a similar verdict, allowing their practitioners to use telemedicine. Next. So we must learn what these guidelines are. So what's the definition of telemedicine? WHO says that the delivery of healthcare services where distance is a critical factor. Say, a person is quite far away. By all healthcare professionals using information communication technology for the exchange of valid information for diagnosis, treatment, prevention of diseases as well as injuries. Not only that, for research and evaluation, and also for continuing education of the healthcare workers, with the aim of advancing the health of individuals and communities. So this is the definition, and it has got a wider scope than what we understand. Next. Next, please. Hello. Yes, next, please. Yes. What are the pros and cons? Everything has got pros and cons. Now, the way we understand telemedicine, that's more than adequate. Remote areas. See, people staying in remote areas do not easily get the advice or the clinical assistance by qualified doctors. Maybe that they are left to the mercy of quacks or left to the mercy of um, some vehicles which will take them to the doctor or whatever. And it is always said that doctors do not settle into remote or tribal areas. While doctors say that if we settle there, where is the work? We cannot thrive there. So if we have got adequate workload, we will settle there. So there is a truth prevailing in both the arguments. But what's the answer? The answer is telemedicine. With telemedicine, people staying in remote area can easily avail the benefit of consultation by a qualified doctor. The doctor might be sitting in a remote area or maybe sitting in a district place or a city. Disasters and epidemics. Believe me, during my long career, I have been at the epicenter of number of disasters and epidemics. And what I have seen is that there are institutes, there are organizations, there are NGOs, the government, everybody is there to help. But what do they help? What do they offer? They offer food. Food is vital. They offer potable water. They offer clothes. They offer basic amenities for survival of life. They also offer medical services. They organize some camps and they settle down, having some camps. The doctors are there, but then each and every person is in need of medical help, and it is difficult to reach out in remote areas where the calamity has struck. So what's the answer? Telemedicine is the answer. It cuts short time in emergency. We must have heard many times that a person was ill, had some injury, or a lady was bleeding at the time of delivery, or had a chest pain or whatever. And this person was rushed to a hospital or a clinic where a doctor said that, well, you need to go to a hospital because I am not in a position to treat such a complicated or a serious case. They go to a hospital where they find that the doctor is on leave or away. The hospital is closed. They go to some other hospital and where the doctors find that there is a dead body. Or they say that if you had come a little earlier, we could have done something else. If the person had sorted to telemedicine, he could have been directed to the correct place and the shunting time could have been reduced. Reduce space and staff requirement. See, suppose if a busy running family doctor is having an average OPD of 100 patients a day. 100 patients means 100 attendants also. That makes 200 people visiting his office in a short time of his clinic. So there are so many people assembled there, and you require a very large space to accommodate them. Now, if you think in terms of COVID, you need to have social distancing. So for 100 patients and 100 attendants, maybe that at any given time there are 30-40 patients and 30-40 attendants. You will require a cricket ground or some such large space to accommodate them with a social distancing. This is impossible. You require as many people for registration, as many people for counseling, as many people for cleanliness, and so many requirements. Somebody to give injections, somebody to explain how to take medicines. Rather than that, if you resort to telemedicine, you cut short at least 30% of your OPD, and your space and person requirement would be reduced. You remain competitive. Everybody knows that if a doctor in a locality has got some good facility with him, the other person also needs to have the same facilities. This applies to all professions and business, and not only to doctors. But you require the same facilities, then only you stay in the market, stay in the business, stay in the profession. So you need to be competitive, and you need to survive. Survival of the fittest. Again remembering Darwin. So if you are fit enough to compete, then only you survive. Otherwise, your competitor will take an extra edge. So if he starts using telemedicine, you need to widen the geographic area. See, what's the drainage area of a doctor? If he is a family physician or a general practitioner, people come from his society or a nearby locality. If he is a surgeon or a physician, chest medicine specialist, maybe that people from his district come, some nearby villages and some nearby places. Only if he is a super specialist like transplant surgeon or interventional cardiologist, then maybe sky is the limit, and even medical tourism can be resorted to. But these are a few people who can do this. Otherwise, you have to have a catchment area of a small locality. But with advent of telemedicine, a person sitting in Mumbai can treat a person sitting in Chennai, while a person sitting in Kolkata can treat a person sitting in Jaipur. So this is the crux of telemedicine. You can treat the person who is very far off away, but not across the country borders. See, you cannot treat a person in another country because, hi Rabia, because uh, the rules and regulations must be parallel, and the different countries may not have such parallel rules and regulations. In India, we can treat the people across the country, but in US, what I understand is that the state where you are registered to practice, you can treat via telemedicine only the residents of that state, not beyond the state border, within the country also. So these are different regulations. But what's the benefit to the patient? Think of a person who is staying in a village. In that village, there is no doctor. The person needs to get a consultation from the doctor, and who is sitting in the city. Now, how can he travel from his village to the city? Either he takes a public transport or he takes his personal vehicle. Personal vehicle is very costly, and maybe that he will not be in a position to drive. He will require an assistant. He will require somebody to. Well, it becomes a costly affair. But public transport is also a costly affair, because public transport do not ply at the time when you require. They ply only at the time where there are passengers. So if there are more number of school children going to the nearby city school, the buses will ply during the school hours. So they'll start early at 6:30 in the morning, will reach the city at 7:30, and the children will reach their schools in time. But if you go by that bus, no doctor will come to their clinic before 10 o'clock. So what will you do by that time? And do you sit there, or you move around, or you do some shopping or some marketing, or if you are little less ill, wait for the doctor. The doctor examines you, asks for some laboratory tests or something, x-rays. You get the reports, you go again back to him, you take the suggested medicines, go to the bus station where the buses ply to understand that the bus available for your village is at 6 p.m. The entire day is used. I will not use the word wasted, but it is used away. And what do you think is a daily wage of a person? It could be around 200, 300 rupees minimum. A person in a better business or better a shopkeeper or somebody might be earning much more than that. And those 300 rupees, a bare minimum of 300 rupees, plus a person who was attending, again his wages, and again the bus fare for both of them. And if you go there in the city and stay there for entire day, you will require to take some lunch, and you will require to take some tea, and you will require to take some local conveyance, and everything put together might become 1,000 rupees. And still we have not counted a single penny for the medicine or the doctor. So it's very costly. It costs you 2 main days and some 1,000 rupees. Rather than that, if somebody advises you to take some medicine on phone, you don't. You take only 15 minutes. You can start working or you can rest. No, you don't need any attendant. Only thing is that you will need to say somebody that, okay, please go to the city and bring some medicines for me. And there are always quite a few people who are going to the city for their business, for their purpose, and they will oblige by bringing medicines for you. So a lot of time and money are saved. And to add to it, the suffering. A person has got a lot of backache or joint pains or fever or whatnot, has to travel, has to be moving around in the city or sitting in the waiting room for entire day. What a lot of suffering, what a huge suffering he is taking. And you cannot calculate it in money count. So this is another issue. So people are very happy using telemedicine, especially those in the remote areas. Record keeping. Yes, electronic record keeping is definitely better than the record keeping which is done manually. Only thing is that you need to use those electronic record keeping devices. And better triage. Yes, what you need to do is this, that you find out that the person is requiring some emergency attendance and tell them that rush to the hospital rather than um, wasting your time. And rush to a particular hospital where the facilities for your treatment exist. Second point of triage is that you say that, okay, you will require some treatment which is not possible at my clinic, or it is beyond my capacity to do so, or beyond my specialty to do so. You go to particular place. And maybe that you will say that, well, in your case, I would like to clinically examine you, and without clinical examination, I will not be in a position to come to any conclusion. So better you come down to me, or you go to your a doctor nearby you. He will examine and will treat you. So these are triages for telemedicine. What are the cons? Missing personal touch. See, you must have heard quite many people saying that, doctor, you are so sweet. that once we start talking to you, half of our pain goes away. Such kind of interpersonal relationship is missing in telemedicine. We have to take care to become that person. But while in physical situations, you can pat the shoulder of a person, you can say that, okay, gentlemen, you are not to worry, you are a strong man, and you will be okay. So that kind of a feeling you need to imbibe to the person while you are teleconsulting. That's a challenge. That's a con. Patients may not be comfortable or used to technology. See, it requires some technology. And even we are not used to take up the challenge of using technology. See, I am an old person. Many a times I request Srestha to do something for me because I am not accustomed to use this technology and I'm fumbling. And the younger generation people, yes, they are kind enough to help me out. But the fact remains that I am fumbling in using the technology. If I am fumbling, what to think of a remote villager or a tribal person? He will definitely fumble using advanced technology. Lesser opportunity for clinical examination. Now you might say that where is any opportunity for clinical examination? Yes, it is to a smaller extent. Say if there is an extension worker, like a health worker, or government has employed many health workers. Many of the hospitals send out paramedics to uh, home visits, and even the ambulance medical technicians, they also take help of telemedicine. They contact to the doctor eating in a remote place uh, regarding advice to how to manage the patient, the initial management. And according to his advice, the initial management is done. But then the person feeds some clinical findings and you have to believe him. The person is lesser to the doctor. He is a paramedic, or maybe that he is a junior resident talking to head of the unit or professor that we have received a patient, I have taken a cardiogram and this and that, I have clinically examined. Now, naturally, that junior doctor is not as competent as the professor. But the professor will have to settle with these inputs, or he will have to personally come and see. So if he is satisfied with the clinical acumen of his junior, he may take a risk not coming to the clinic and advising on phone. So there is a dependency on other persons about the clinical features. If not on video, non-verbal clues are missed. See, if a person is talking, but then you can't see his face. If he is in agony of pain and grimacing, you don't see. There are so many non-verbal clues. If it is a video call, then yes, you can see the face and you can see the facial gestures, but only the facial gestures. In a physical or a clinical setting, you can observe the person in toto, entire body, right from the time he enters into your clinic, opening the door and asking, "May I come in, sir?" And you can see his mannerism, you can see his gait, you can see his dressing, you can see his uh, voice, you can hear his voice, you can look at the articulation, you can look so many things, which give you number of clues. These are missed. So clinical setting allows observation of so many other things. Palpation and percussion, and these are out of question. Well, I'm not putting auscultation because stethoscopes are equipped with electronic devices which can transmit sound to our remote doctors. Net and use of newer tech gadgets at both ends. See, the doctor is sitting at a district or a city place where net is available, connectivity is available, all the kinds of sophisticated technological equipment are available. But it's not so for a remote person. Maybe in developing countries, you will find entire villages which are not having any kind of connectivity. Or if connectivity is available, you will have to move out to crossroad, come out from your home, uh, reach out to the crossroad, and then you will get some signal, and then you can talk to the other person. So it's all very difficult. Next. Now, which media are you using? For video call, we can use Skype, we can use WhatsApp, or you can use other platforms like Zoom. Audio call, yes, we can use phone or even basic phone or landline phone. For WhatsApp, SMS, other chat platforms, for written communication, email, fax, and even simple post is also a telemedicine way of communicating facts. And what's the time? What's in relation to time? I'm not talking about AM or PM, but it's real time when both the people, both the persons at both the ends, they are talking at the same time. Say this communication is going between you and me, that's real time. I am just now speaking and you are just now listening. And when there will be some question answer session, you will be asking some question, you will be having sharing some inputs, you will be sharing your experience, and everybody else will be listening to it. You put something on chat and everybody reads just now. So this is real time communication. But if this entire session was recorded and put on YouTube, then you would be seeing it at your own leisure time if you are interested. At that time, I might be doing something else. So it's not the time when I am speaking when you are seeing me. And it's not the time when you are asking question, I am available on the other end. So maybe that if you ask some questions, many of the platforms allow that the other person will answer you, but will answer you at his time. So this is an asynchronized way of communication. So this is asynchronized. But many times there is a mix of both. Say if a patient talks to a doctor that, well, doctor, I am having some chest pain and something this and cough and fever and all these things. The doctor would say that, okay, you better go and get some laboratory tests and X-ray test done and come back to me with the reports. Now, this much was real time. Now the person goes to radiology, X-ray or laboratory, gets investigations done, and the reports he sends via WhatsApp to the doctor. But at that time, the doctor would be busy doing something else. He will see the WhatsApp and the reports at his time. And seeing at the reports, he will advise some medicine on as a response to WhatsApp chat, which the other person will see at his time. So to start with, it was real time, but it ended into an asynchronized way. This is a kind of a hybrid way of teleconsultation. Next, please. Now, which are the hurdles in telemedicine? Connectivity and smartphones. See, the person at a remote place should have smartphone. Maybe a simple phone will do, maybe a landline will do, but so many things will not be possible to be transmitted via smartphones. The technology would be much easier to transmit information if you use smartphone. Now, luckily, smartphone has not remained a big hurdle because the person himself might not be using smartphone, but according to number of surveys, at least 75% of families have, even in the remotest areas, have one smartphone in their family. Maybe that the son is using it. Maybe that the main member of the family is using it. But there is availability of a smartphone. And for remaining 25%, you can have smartphone in your neighborhood, which they will definitely allow the use of at the time of medical situations. And in other surveys, very recently we had conducted a survey for our upcoming project of telemedicine. We surveyed and found that almost all families in that particular district were having smartphones, even the labors of industries. So smartphone has not remained a big hurdle today, but connectivity is. Connectivity might be difficult to have that much of use, because sometimes it's available, sometimes it's not available. The bandwidths are a problem. And that's why whatever platform you use should be compatible with low bandwidth. At least it may be compatible with 2G. Making smartphones available with workers is another way. Say in Odisha, in one of the projects what we are running, we have offered them, rather our partner NGO has offered them smartphones. The workers go out in the community and talk to the doctor regarding the health of the person. They are equipped with smartphones. So that's the easy way. But the bandwidth has to be addressed. And the platform what we are using is compatible with 2G. Not only that, it is available offline also. So you can register all the details as if you are using the live app in your smartphone. And that detail will be uploaded once the phone gets connection of connectivity. And every 15 minutes, it will try to sync its details and upload the information. Next, please. So these are the ways out. Various combinations of consultation. So the easy way to understand is that a doctor and a patient. The patient rings a doctor and say that I have got this. The doctor says, okay, you take paracetamol and you'll be all right. But then there is doctor to client. See, I am not suggesting a situation that bank will ring you and say that, well, loans are available at very low EMI if you want to have some home loan or vehicle loan or whatever. I don't suggest that doctors should go to that extent. But maybe that yesterday a doctor had seen some patient whose condition the doctor was not very happy with. So he rings him up in the morning, worried about the health, and says that, well, how are you doing today? So such kind of a follow-up activity, the doctor might communicate to the client. There can be a health worker. As I have suggested that government health workers are there. There are certain extension workers or health-oriented people which are employed in some of the projects. They are quasi-qualified, quasi-trained, and they collect some information from the patient to be fed to the remote doctors. So health worker to a doctor. Maybe that this situation is available in a hospital where during emergency hours, if a patient is received and the doctor is not available, many of the private hospitals where only single doctor is there, their nursing staff or the paramedic is available 24 hours, will examine the patient and will feed the doctor that we have received such a patient. The doctor advises some treatment and comes down to see the patient, but by that time, the treatments are initiated. So health worker to a doctor and a doctor to a doctor. Maybe a junior resident to a professor, or maybe that you are talking to your colleague. for confirmation of your diagnosis or to rule out some doubt. Things are self-explanatory. But when a peripheral worker is involved, yes, you can have some clinical examination inputs. And when a doctor needs to the another opinion, maybe that a radiologist is there, maybe that he would like to confirm the implications of a pathological investigation, or maybe that he is perplexed with the clinical presentation, he would like to get a confirmation from his colleague or a senior doctor, whatever. Next, please. How do we conventionally proceed with the patient? We take history. We perform clinical examination. And in the light of history and clinical examination, in the mind of a doctor, there is a provisional diagnosis, 1, 2, 3 provisional diagnoses, that either it could be this, or it could be this, or it could be this. Now, how to confirm what it is? Then some investigations are suggested to confirm or to negate a diagnosis, or to find out the modality of treatment, that whether particular treatment is suitable for giving to the person or not. Because if the person is having some kidney problem or some liver problem, some medicines cannot be given. So the investigations, and at the end of investigations, you are sure with the diagnosis and you draft a treatment plan. And how to transmit these informations? Well, history is a text, and that can be transmitted as the text is transmitted. Clinical examinations, yes, it could be text also. Sometimes it could be image. Say, for example, a skin lesion. That skin lesion is photographed and sent to a remote doctor. So it could be, clinical examination could be an image. It could be a sound, a murmur of a heart, or a heart sound, or a respiratory sound, or bowel sounds. Now, such sounds are captured by stethoscopes. And today, electronic stethoscopes are available. They are available with our agency also. And if a peripheral person is equipped with such a stethoscope, the electronic device attached to it connects with a via Bluetooth to a smartphone of the person, and with that smartphone you can connect it to the remote doctor via internet. The sound is converted into wave file. The remote doctor listens to it. He can store it. He can retrieve it. He can listen to it 15 times, come to a conclusion, and this way sound is also. And video, yes. If you want to have a video of some movements, or some a video of some radiological images, and these can be transmitted by a digital way to remote doctor. Yes, everything can be transmitted. Provisional diagnosis, yes, it's text. Investigation, many times it is text. But if you want to transmit a picture of a histopathology site, you can do it. And treatment again is a text. Next. Yes, you cannot give a shot via telemedicine. The consent and liabilities. See, if in clinical setting we need to take some consents, and sometimes we don't need to take some consent. If a person comes to office of a general practitioner or a doctor and waits for his turn, enters the chamber, sits next to the doctor and says that, "Oh, doctor, I am having some pain in abdomen and some loose motions, and I feel like getting nauseated, or I might vomit out." Well, that means that he wants the doctor to treat him, to examine and then treat. So for examination as well as treatment, you don't need to take a consent. It is implied that the person has given consent. A person will not come and sit next to you, wait for his turn, and say that, okay, I am having some diarrhea and vomiting, and this is for the purpose of finding out the resale value of his used car. No, he never comes to you for finding out resale value of his used car. He comes to you for treatment. So it is implied consent that he has given a consent that you can examine him and treat him. But if you want to do something beyond that, say give some blood transfusion or do some procedure or some operation, then you might need to take some consent. This is a clinical setting. Similarly, in a telemedicine situation, if a patient rings up a doctor and says that, well, I am having these issues, he does not need to give any consent, or neither the doctor needs to take any consent, because it is implied that the person has himself urged the doctor to do so. But when it is doctor to patient, maybe that tomorrow a doctor will try to find out the condition of a patient. Meanwhile, overnight, the patient might have changed his mind, might have got admitted to some other hospital, might have been taking treatment from some other hospital. He doesn't want any treatment from the original doctor. So now the doctor needs to take some consent, because it is not implied that the patient wants the treatment. Similarly, if a health worker does something on behalf of a patient, the patient doesn't know who the backend doctor is. And maybe that if he was knowing, he would have refused. So the consent should be taken that this is a backend doctor and we are going to get your treatment from him. Well, from doctor to doctor, you don't need any consent, except for saying that I would like to, without revealing your identity, I would like to discuss it with my colleague. And if you are not disclosing identity, you don't need to take any consent. And you are going to, the doctor is going to give a prescription. So all the responsibility lies with the doctor. The doctor would like to share the responsibility by putting notes on his case paper that Dr. So-and-so was also consulted, and he also has agreed to this treatment, or he has suggested this kind of treatment. That's why doctor to doctor doesn't require any consent. Legal liabilities are the same as clinical setting. But the legal liabilities say that you will take the utmost possible care. The utmost possible care is different in different settings. Suppose if you are there at a remote place conducting a diagnostic camp, or you are just traveling by and somebody stops you seeing a doctor symbol on your car. Oh, doctor, please do something for us. Well, at that end, your utmost care is different than when you are in a ICU of a multi-specialty hospital, or maybe in operation theater. The utmost care would be defined altogether different. So telemedicine has, you need to prove that you could have done better than this on telemedicine. So maybe that you would like to advise to some patients that it's better if you physically examine and get the treatment. I would like to examine you for a better response. Maybe that would be adequate. Record keeping is very important, even more important because you have not really seen the patient. Establishing identity is also very important. Well, you can say the person has rang you up, so he knows that he is talking to some doctor, a particular doctor. But you don't know who the other person is. So somebody might say that I'm Joseph. And doctor, I have got some loose motions and I have got some fever and I have got this and that. And you suggest some treatment after listening to him and asking some questions and everything. Now he says that, well, doctor, because I'm performing a job, my employer wants a certificate from a medical doctor that I'm not in a position to go to work, a medical leave. can you send me a medical leave certificate on my WhatsApp? You can say that, well, I have examined Mr. Joseph, and he is suffering from this, and he may be given rest for 3 days from his job. Now the trick is here. The person is John and not Joseph. So John gets his treatment, and Joseph gets a certificate that he is ill. Now we can make use of that illness certificate anywhere. In India, for all medical legal purposes, telemedicine is not allowed. But it is allowed in some other countries. So you need, and tomorrow in India also, such issues will arise. And when they will arise, you will have to have some idea, some way out of it. So how to establish the identity? If there is a health worker besides him at a remote place, well, the health worker will establish the identity. Or if you are on a video call, you take a screenshot of the person and can say that, okay, well, I have examined this person, and he requires this kind of a treatment. Maybe that you will take Aadhaar card number or some other identity also. As the time passes, the things will get clear. I don't know what's the practice in other countries, but there are friends who are from other countries, and we will look forward to their inputs like that. Yes, and the other liability is the look and the setting. See, if you are very conscious about the appearance of your clinic, your appearance in the clinic and everything. You are decorated in an apron, having a stethoscope, and sitting this way, and the table is with such kinds of equipments, and there is a X-ray viewer there, and a computer there, and everything is decent. The same should be on a video call. So if suddenly, even on a webinar, if suddenly somebody says that, okay, please switch on your videos, then maybe that somebody is in his banyan or might not be in a position to show off the face. This should not happen with the teleconsultation. When you appear on the video, you should be conscious about your appearance, the background of the room where you are sitting, and everything. So these are the consents and liabilities and legal liabilities which will unfold and will tell us so many things as our experience ripens. Next, please. Teletriage we have discussed. Next. Yes, a telemedicine doctor can refuse teleconsulting a patient at any given time. In clinical setting, you can refuse a patient from the very beginning. You can say that, okay, I am not in a position to take your case because I will not be, I am scheduled to go out on my vacation, and I will not be available in the city for 10 days. If I take responsibility, well, I will not be in a position to fulfill. And that's why I would suggest that you better go to some other place. But once you have accepted the responsibility, you cannot shy it away. Here what I am saying is refuse teleconsultation of a patient at any given time. Even after 2 consultations. But see the words. You cannot refuse the patient. You can refuse teleconsulting. At some given time, you feel that you better examine the patient clinically. Then you will say that, okay, at this juncture, I feel that you need to be examined in person. So either come down to me, or if you are very far off, maybe that a doctor of your choice or a doctor in your vicinity, he will examine and will treat you. So this can be done. You can ask for physical examination, and you can charge reasonable fees. But you can never force teleconsultation if the patient wants physical examination. If the patient wants that you must physically examine him, then you cannot say that, no, I'll talk to you on telephone and it's more than adequate. Then even for all silly things or petty things, you will have to physically examine him if the person insists. And a telemedicine doctor must observe confidentiality of all patients, offer full attention and adequate care, keep records, observe required professional etiquette. And what we are not doing in physical setting, we are doing all these. The same things we need to do for teleconsultation. But there is a big difference. All the records are in your custody or in the hospital's custody. And at the discharge of the patient, we give a discharge summary. The detailed case records are in the custody of hospital. The physical custody is lock and key. Nobody can touch it except for the authorized persons. But here they are electronically stored and hackers can hack the information. So for personalized informations about the patient, what he would not like to get divulged to the society or community at large, you need to store this information at a very secure way, having some protection so that the hackers cannot easily hack it. So this is an extra requirement and a telemedicine platform should offer that. Next. What services can be offered? Counseling, advice, psychological support, diagnosis, treatment. Yes, you cannot give a drip of saline. Neither you can deliver a baby or give a plaster cast. All things which can be remotely done can be done on telemedicine. Next. The classes of drugs. Now, these are the things for Indian audience only. There are list O drugs or list 0 drugs. These are the over-the-counter drugs. You don't require prescriptions to get the drugs, and the pharmacist can jolly well give these medicines to you. Like paracetamol, like ORS, antacids, cough syrups, tonics, multivitamins, or some medicines which are used in national programs. These have been classified like chloroquine in malaria. These are classified as list O drugs by Medical Council of India. This doesn't pertain to any other country. List A drugs are the drugs which can be given for conditions which can be diagnosed on video call. Say if it is a skin condition or something like that, when you can easily diagnose the condition on video call, the medicines for that are classified as list A drugs. And in list A drugs, refill of chronic conditions is also included. Now what's the refill? Say if you are hypertensive and you are taking treatment for hypertension. Now this treatment you will be taking lifelong. The first prescription cannot be given like that. But once you say that, well, I was advised this, I am taking this medicine, I had taken this medicine for 1 month. In last prescription, I have been taking it for number of years. Now I have exhausted the medicines and I want the supply. So this can be done as a list A drug. And list B drugs are the drugs which are the top-up drugs. Say if you are a diabetic, you are taking some treatment and you are monitoring your blood sugar on glucometer by yourself. And you say that, well, doctor, I am not keeping well. The glucose control is not good. Glycemic control is not so good. The doctor would think that, okay, rather than having some medicine right in the morning only, he would like to add another thing at the time of lunch. So this is an add-on drug. This add-on drug is listed into list B drug. So whatever is given as an add-on is list B drug. And there are certain drugs which are prohibited, which can never be given in telemedicine setting. And these are some narcotics or Schedule X drugs or anti-malignancy drugs, etc. Now, because in India, telemedicine knowledge and experience is very limited, these instructions are likely to change in the light of the experience or the situations or the developments. And the first change has already come. In the list A drugs, they have added some psychiatric conditions. We are going to have a look at that also. Next, please. Now, what is first consultation follow-up visit? When a person is examined for the first time by the doctor or teleconsulted for the first time by the doctor, a new case, that is first visit. But if a person is taking antihypertensive from a doctor for quite some time, and today he develops fever, so it's an altogether a different kind of a condition. He is an old case for hypertension, but he is a new case for fever. So the drug regulations, which we are going to see in the next slide, that certain things which can be given on first visit, certain things can be given on second visit. So that applies here. That for antihypertensive, you consider it to be a follow-up visit, but for fever, it's a new visit. But if the person is having cough, the person on antihypertensive is having cough. And if he is on ACE inhibitors as a side effect can induce cough. So again, now you have to judge whether it is because of side effect. Then if it is because of side effect, it's an old case. If it is because of tonsillitis, it's a new case. Or if 6 months have passed, the person was taking regular treatment from a doctor, but somehow or other he missed, visited some other place or whatever. 7, 8 months later, he again returns to the doctor. Now he is a new case for him because many things can happen within that time. Now you'll wonder why this could happen. This happens with the elderly people. See, my own mother, she is under treatment of a physician over here. I am staying at Rajkot. And a friend of mine is taking care of her. But sometimes she visits my brother's place. He's at Ahmedabad. Now, when she's at Ahmedabad, she needs some medical opinion. She consults some other physician there. And when she comes back over here, Rajkot, and she needs physician's care, naturally 6 months have passed. So this is a new case for that physician, the same patient, the same doctor, the same condition, but will be defined as new case. And if the same doctor, same patient, same condition, not 6 months, but you don't have records, neither you nor the patient. So how are you going to prove that you were treating the patient? In that case, the person is a new case. Old case or a follow-up visit, same doctor, same patient, same condition, less than 6 months. Simple. There is no other option, no other issue, no other classification. Next, please. Now, drugs which can be prescribed. First consultation, you can prescribe list O drugs. That's OTC. You can say that, okay, you can prescribe, you can take paracetamol. And the next day, if he says that I'm not very happy, you can add some other drugs. So then because the person is in a follow-up visit. So OTC drugs, National Health Program drugs, which can be given by multipurpose health workers, and some emergency medication. You can say that, okay, you take this medicine for the relief by the time you can reach your doctor. See, the person has got renal colic. You may suggest that you can take this medicine. you will get less pain. You'll stop getting vomit, and you then reach to your doctor who will further treat you. Or tomorrow morning you can visit the doctor. So this is list O drug. If the first visit is on video call, then you can use list A drugs also. Say if a skin condition, some conjunctiva problem or some knee joint problem where there is a swelling, and you can point out, you can see the person walking with a limp and everything. So these are the conditions which you can diagnose on video call. The medicines for that, whatever medicine you feel like, will be classified as list A drug and can be given on first visit. List A drugs can also include the refill of the drugs. But refill of the drugs cannot be given on first visit, because then it is not refill, it is first prescription. So that can be done on subsequent visits. For follow-up consultation, list O, A, B, everything, except for the prohibited drugs like narcotics and others. And here in list A, you might see that it is written that some psychiatric drugs are allowed in recent amendment, like phenobarbital, clobazam, clonazepam, etc. Now there are restricted things, and people qualified enough to use these medicines can prescribe that. Next. Now, regarding prescription, how do you send prescription to the person? You may say that you take paracetamol, but how can he take paracetamol on your talking to him? He will have to show some medicine, some evidence to the pharmacist so that he will dispense. So a prescription has to be there. And prescription can be communicated by mutually agreed means. It could be WhatsApp, it could be email, it could be text, it could be fax. Now you may say that I will fax the prescription. The person says that, well, but I don't have a fax machine. How will I receive it? So it has to be mutually agreed upon. It could be on WhatsApp, it could be on SMS, whatever. And it must contain name, age, gender of the patient, of course, the identity of the patient for whom you have prescribed, name and registration number of the treating doctor, your details of means of communication. See, a prescription of a doctor usually has got the address of his clinic and phone numbers. Why address? Because the person knows where to contact the doctor. The time also is written on that the clinic times are this. But here there is no clinic. You are contacted on phone. So the prescription must contain the ways to communicate, the time to communicate. Provisional and final diagnosis has to be there, and signature of the doctor has to be there. You put down your signature, take a photograph. You can put electronic signature also and send it. But it cannot be sent directly to the pharmacy without patient's consent. You cannot say that, okay, I'm sending this prescription to ABC pharmacy. You go there and take treatment, take the medicines from there. Naturally, for obvious reasons. But people might say that you have got some commission practices with that ABC pharmacy. Why should I go there? And again, see, if the person is suffering from HIV and he doesn't want that ABC pharmacy person to know his HIV status, he is comfortable with the person whom he knows. So it's his right, his choice to select the pharmacy. We cannot send it to pharmacy directly. And must be preserved in such a way that it's retrievable. At any given time, if somebody wants to know what kind of medicine you have given him, you should be in a position to find out. Next. Advances. Teleradiology, telecardiology, telesurgery, telepsychiatry, teleophthalmology. any branch, and it's using telemedicine. Next. Now let us see some applications. In radiology, be it simple X-ray or be it CT scan, be it MRI, be it sonography, whatever, the images are captured in a digital way. The old-fashioned X-ray machines are out. Now, whatever has been captured in a digital way can be transmitted in a digital way. So all the images can be digitally transmitted. And many of the hospitals, they have eliminated X-ray plates. The X-ray images are directly communicated to the doctor via LAN, via email, whatever. The doctor who has requisitioned. Or, and the doctor on their computer, they retrieve it. In fact, in India, there is a shortage of radiologists. Radiographers are available. So, X-rays can be taken at remote places. But if there is no radiologist, who will opine upon that? Many times it so happens that the clinician sees the X-rays and comes to a conclusion. But sometimes you will require a radiologist to opine upon that. Only clinician's opinion will not do. So in that case, what to do? So government in India has established teleradiology centers, meaning thereby that the peripheral hospitals are connected to nearby medical colleges, of course, by email. And the radiologist at the radiology department of a medical college will see the images and will opine upon them. So that's already available. Multi-specialty hospitals send through LAN, and many radiologists, the images are taken, the CT scan is done by a radiographer or a technician. The radiologist is far away. He examines that on email and will opine upon, will give his opinion. This happens. In cardiology, ECG can be transmitted by. It's not that you take a photograph of a cardiogram and send it on WhatsApp. The ECG machine itself is connected via Bluetooth to the smartphone, and the ECG tracings are transmitted via internet to the remote doctors. See, for a project I was moving in Jaisalmer district. Jaisalmer, you might be knowing that it's a remote district in India. It's bordering India and Pakistan, and it's in a desert. So experts are not available at all the hospitals. Physician is available at the district hospital. So peripheral hospitals have got this kind of ECG machines. The doctor takes ECG. The tracing will directly go to the district hospital. The physician there will examine the ECG and will give opinion. This is done. Holters can be are most of the times connected to the treating doctor, and 24 hours monitoring of cardiac activity can be done. Multi-para monitors of ICU are connected via internet to the critical care physician. Digital stethoscope, what I have already, electronic stethoscope I have talked about. Next. Surgery. Robotic surgery is a telesurgery. See, now the person is sitting not in the operation theater, but in the hospital somewhere else, or maybe in some other building, and guides the robots inside the body to perform the surgery. Surgical assistance can be given by sending live video. If a doctor is put to trouble, and if he is recording the live video of the surgery, he can transmit it to a remote specialist, other doctor, other colleague, maybe senior, and seeing the video, the doctor will advise that, okay, you do like this, and you will be out of trouble. Teaching and mentoring surgical procedures by live streaming. Well, it's a well-known way to treat, to teach. Dermatology, yes, clinical photographs are more than enough for dermatologists. Psychiatrists can talk on video call, counsel, perform tests like Rorschach, TET, etc. Ophthalmology, even pictures of live video retinoscopy can be transmitted digitally to the remote ophthalmologist. Next, please. So, pathology. Microscopic pictures are transmitted. The histopathological slides the pictures of the slides are transmitted, and the person sitting at a remote place can see the slides and can opine upon, can diagnose. Many instruments like glucometer, autoanalyzer, even the weighing scale and BP instrument are also connecting via Bluetooth to the smartphone and enter into the Google Sheet the values, what they have found out. So now it will transmit the value. So 47 will never become 74 as in manual entry. And the remote doctor will immediately see the results. One of my friends is conducting a Facebook page, and where he's a pathologist. He puts some histopathological images, and his students and the participants they have a debate on the images, and next day he will give the correct diagnosis. So this is a way of teaching. These things are going on. So, well, the newer advances require good IT knowledge. They are usually between doctor or paramedic. However, Holter and robotic surgeries, they are involving doctor and the patient. Next. Well, for COVID, we skip these things. It's the case study of Chikitsa Sahayata Kendra. Now, this is our own project of telehealth. And today, the project has taken some different dimensions. But this was an original, the earlier studies, and which we needed to put it at some other platform. So the findings are this, that 81 villages were covered, 1,673 patient visits. These are the earlier figures. And out of those 1,600 patients, the satisfaction rating was 4.61. Next. Now, the platform and software provided by telehealth are based on allopathic history taking and clinical protocols. History taking and clinical protocols for Ayush differs. This platform software and mind maps used to develop program are for use of allopathic practitioners only. Ayush doctors are encouraged to develop their own mind maps and protocols. Now, this is something what we need to say as statutory warning. Next, please. Yes. Now, improving health access for most vulnerable. Something what we had seen, 1,600 patient visits, etc. 70% of the patients belong to scheduled caste tribe. 69% were women, 99 below poverty line, and 60 people did not have formal education. Now you will say that how did they use smartphone? Smartphones were used by the extension workers. We call them semiotikas. And you must have seen the first pictures. A lady was sitting with an apron on and all these things. She did everything for the patient and connected to the remote doctor. Next, please. Now, what happened? 16,000 hours was the time saved to access primary health care. Now, as we had already discussed that one day, entire day would be used up for taking consultation. And that too could be for two people, not for one person, one attendant also. combining all these factors together, during those 1600 visits, 16,000 hours, so 10 hours per visit were saved. Is it not, Mehmet? 74,000 kilometers was the distance travel saved, because the people will have to travel to the doctor, and of course maybe two people to and fro. So out of 1600 visits, 74,000 kilometers were saved. It's again Mehmet. You might say that it could be hyperclaim, but it's true for tribal area. Tribal area are well scattered, and you don't have a lot many facilities in a nearby way. Even the villages are 10 households, a small village, and again after say a kilometer or so, there are another 10, 15 households. So this is a scattered area, and 74,000 kilometers was the distance saved. $25,600 was the money saved to access. So it includes the daily wages, and it includes the transportation, etc., and the demurrage of daily expenditure also. 61% demonstrated full compliance. Now you will ask me that, well, on telemedicine, people may not take your advice and may not take the treatment according to your advice. It happens, yes. Even it happens in clinical setting. In clinical setting also, people say that it is 60-40. 60% full compliance, 40% partial compliance or no compliance. Here also it was something like very similar. We also don't take full course of tinidazole if we have got big dysentery. 95% patients reported that they got better. And 99% said that they would recommend telemedicine to others. So a very high satisfaction, a good lot of money and time saved, and equal compliance. So these were the results. Next. This is one of the Sanyojikas. Thank you very much. Here, my email ID is there. If there are some questions, I'll try to answer. If you are having some inputs, you are most welcome. If you have got some experience to share, again, you are most welcome. You will enlighten the entire group. So please feel free to talk, to ask questions, to share experience, everything.
Yes. Thank you, Dr. Butch, for the lovely presentation. As Dr. Butch is suggesting, we would also like to hear from you, your experience, we would like to hear. And if there is anything that you would like to add, or maybe how telemedicine is working at your side, at your part of the world, how it is being used, and we would like to know about that. So I would request if somebody can unmute, come up and unmute and then share experience. If not, you can definitely write it in the chat box. And are there any questions? Anybody would like to ask any question, or maybe they want to share something? Okay. I think there are no questions.
Maybe Nishan, would you like to give the demo and talk about our platform?
So I would like to welcome Nishant. Nishant Singh is our Director of Partnerships. He'll be explaining all the participants about our work, how IntelliHealth has been working um, uh, in the telemedicine platform. So, Nishant, over to you.
Yeah, hi. Hello, everyone. Thank you, Dr. Butch, for such a lovely presentation. As Dr. Shrestha has already introduced, I'm Nishant and I'm the Director of Partnerships within Delhi Health. And I majorly look after developing new partnerships for IntelliHealth with our NGOs and also with government. Plus, also look after. I also take care of fundraising for the organization. So for just next 10 to 15 minutes, what I'm just going to take you through is what is in telehealth, what we do apart from our IPC training and also our telemedicine training. We also have projects on the ground. So I'll just take you through the journey of IntelliHealth and what exactly the technology we are provide and what kind of models we have when we work with our different partners. So I'll just quickly share my screen. Shrestha, you might have to make me the host.
Yeah, give me a second, please.
Yeah.
Yeah, you can share your screen.
Yes, yes. Okay, so as you all know, in telehealth, so our mission is to deliver quality healthcare where there is no doctor. So our major focus population, I would say, is the last mile community in the most rural and the tribal areas, and provide the quality healthcare services to the populations which are living in such areas. Our approach is basically is to provide a technology to a frontline health worker like a community health worker or a midwife or a nurse. And this health worker is basically supported by a digital assistant called IU, which is inbuilt in our application, and which works like an Alexa to an health worker, frontline health worker, which helps them to actually take detailed information about of any patient. So for conditions which are beyond the capacity of a frontline health worker and a digital assistant, basically they can connect the patient to a remote doctor, and these doctors are usually are the partner organizations which we work with. So they are in the network of the partner organization, and we ensure that the right medical expertise is available when an expert can't physically be present to deliver uh, these services, medical services. We provide evidence-based, dignified healthcare over telemedicine. How we work, we have two basically modes of I would say partnership. We work with NGOs and we work with government and also with hospitals to implement our digital health and telemedicine programs. Like I said, for the last mile communities, we bring the expertise in the field in the health, digital health, and support the partner to set up a program in a co-implementation model. So we are not just a service provider who just provides the services in terms of technology to any of our partners. We co-implement the model. We work on the ground with our partners, build their capacity, train them very extensively to how to basically operate this technology and connect patient to a doctor so that they can get the best quality healthcare services. This is what I just explained. We take full ownership of our software and accountability of the outcomes of the project, and we constantly work with the partner to make sure the project is meeting the impact goals. What we provide, like I said, technology, yes, it's an Android based application what we give to our partners, but along with that we also train them. We provide implementation support to the partners plus also data analytics, because data analytics plays a very important role in terms of improving the quality of the program. So that's what we very closely monitor the data which has been captured into the application, and then provide the right tools and also the right information to the partners in order to carry out the best teleconsultations. This is a technology overview with a package. What comes in is an application which is used by the community health workers to screen, track, and monitor patients and facilitate teleconsultations. We already have more than 71 protocols for history taking, physical exams, and clinical decision support symptom conditions in the application, which is supported by the IU digital assistant. We've also provide a backpack kit to of medical devices for point care of diagnostics, which includes a thermometer, pulse oximeter, and various other devices in order to take the primary vitals of a patient, which is very important for a doctor to prescribe any medicines for these patients. Consultation is carried through a cloud portal for remote primary care doctors to provide a real-time as well as an asynchronous teleconsultations over audio or video calls. So in the application, we have already inbuilt a WhatsApp API. So a doctor can easily connect with the patient through a WhatsApp call. And it can be a audio or a video call both. The key feature of the application is that we build our own digital assistant, and the best part is actually an open MRS. So it's a free and open source software, and it is available in multiple languages and can be easily also converted as per the needs of the partners, and even in the local language where in any region, if there is a particular language being used, so the application can be converted into the same language, just to meet the needs of the frontline health worker and also the patients. We provide support to all levels of frontline health workers. We work with the community health workers, we work with midwives, we work with nurses, and we also work with doctors in order to provide the efficient way to capture information and also to provide diagnosis to these patients. And all the decisions supported and guide them is evidence based, and this is all built at Johns Hopkins University in US. We perform teleconsultation. Like I said, we already have an inbuilt API, WhatsApp API into the application, so a doctor can connect over a video or a audio call for teleconsultation and case management with the patient. It's an open source cloud-based technology. So anybody can actually get on a GitHub and take the source code and actually build on that. This can also be hosted on AWS, that is Amazon Workspace servers, Google Cloud, and other cloud providers. The application also works offline and syncs to the cloud when there is no data when there is a data connection. More importantly, the application can be run on a very low bandwidth, that is a 2G network, and which actually solves the problem of uh, basically demography and regions where there's less connectivity. So still the work can be carried out by the doctors and by the frontline health workers in order to capture the information into the application and then upload it for doctors for the reference to prescribe medicine. This is how the dashboard look like for any beneficiary. So you can see the number of patient with specified symptoms which are added into the basically which are registered into the application. Plus also you can see per day visit to the teleconsultation clinic. So month wise you can see that, and there are many other parameters where you can evaluate your program and see how your program is actually been performing. So we and again, this is a highly customizable dashboard which can actually get a lot of information from the application, which can help in again improving the quality of the program. So like I said, it's a Android application, and the minimum requirement to run this application is Android KitKat, which is 4.4 or higher. It works offline and also operates in low bandwidth. It has a cloud-based doctor portal, which can be accessed on accessible on a web and a mobile browser. It's very easy to use, and it's a user-friendly experience. Data collection protocols for primary healthcare. Then there are also video libraries for patient education videos. So we keep on adding videos into the application where an health worker can actually use this video for IEC, that is information education and communication activities in that particular program, and create more awareness about certain diseases, or maybe prevention of any kind of let's say non-communicable diseases, or maybe for a communicable diseases. We There's an option to do an e-prescription, which can be printed with a portable printer, and it can be actually accessed through a tablet or a mobile phone both. uh, can order all People can also order medicines through an entry module with the application. And for data analysis, the all the data can easily be exported into an Excel sheet, which can be further used to do profiling of patients, profiling of region, and other kind of various analytics on the data. Visualization is highly customizable, and like I said, we can customize the entire application as per the needs of the partner organizations. It can be an NGO, or it can be a government partner both. Yeah, so this is how it looks like. So this is our tablet interface, this is our desktop interface, and this one is our mobile interface. The key aspect of our approach is that it's a low bandwidth technology, highly customizable platform, knowledge engine, which is evidence based, created at Johns Hopkins University. We partner with grassroots organization in order to provide the real time, in order to meet the real time needs of the community. We leverage the existing health system. So that is something very important. We are not trying to actually build a parallel health system. We actually get partnerships in such a way that we can leverage already existing infrastructure and build on that and improve that infrastructure by with the help of technology. And we deliver our services with our local health workers, so that there is a trust in the community, because this local health worker can play a very vital role in order to create that trust, and also to bring in more number of patients to the telemedicine clinic actually. So these are our three packages what we offer. One is a DIY kit. So if any organization who has a technical technology team with them, so they can take our source code from the GitHub and develop their own. Then we have a starter kit, which is actually where we provide already existing protocols, that is 71 protocols, and provide 100 user basically login for 200 hours of technical support, and as well as 1 year of cloud hosting for $2,500 per year. And this is just a one-time cost. It's not a recurring thing that an organization has to pay every year or renew subscription. It's just a one-time cost. Then there is an enterprise model as well, where we customize the application. So let's say if there is an organization who specifically wants to meet the needs of community, where they see there's a higher need of let's say mentally, I would say, uh, specially abled population. So we might have to build certain protocols. So that comes into the custom, I would say, model, where we customize the application as per the needs of the organization, and as per so that it best suits the community which they are serving. And the pricing depends on the kind of customization required after we do a program design workshop, where we try to analyze the ground reality, and develop the application as per the reality on the ground which is needed. So that depends on the number of customization required in the application. So these are our four, I would say, projects which we are currently have and have been doing it in the recent past. So we have one project which is based out of Odisha, and we are doing this in partnership with Arogya Foundation of India since 2017, which focuses on primary healthcare for tribals in Angul district. Uh, we are also we've also been working with the volunteer services overseas and Department of Health in Philippines, and it's a national program. And we've been running this program since March 2019, so it's been almost more than a year now. We are also working with the NCD, basically American Medical Society, since March 2019 in Syria, in NCD management for conflicted affected areas in Syria. Then we are also currently this program is has been inactive because of COVID-19 and travel restrictions and other issues in the country, which is basically with the Edging Global for PHC primary healthcare services at women's prison in Haiti, and we've been doing this in collaboration with Health Through Walls and Edging Global since March 2018. So these are our four projects, but currently we have also partnered with the government of Gujarat in the Morbi district to basically work with the community health officers in order to provide telemedicine support in the Morbi district with 90, I would say, community healthcare officers. These are our some press releases which you can always log on to our website and see various different press releases what we have published at different platforms. Plus also recently for COVID-19, actually we have also developed an application called IntelliSafe, which is an e-learning platform for essential service providers. And when I say essential service providers, it's just not for only health providers, even for teachers. It is even for ambulance drivers, for anyone who's actually resuming their day-to-day activity. And this basically provides again an information on how to take care themselves while they're at their jobs, and gives them an detailed information of how they can reuse their PPE kits, how they can make their own mask, how they can don and off their mask, and various other information, so which keeps them actually safe and sound while they are at their jobs. So yeah, so that's it. You can find out more on our website called www.intellihealth.org, and you can dive into even detailed case studies of our project and see how we have been working in different parts of the world, and trying to solve the problem of access to healthcare services, especially in the last mile communities. Yeah, so these are some pictures from our Indian project in Odisha, where a frontline health worker basically taking the vitals of the patient, and then the remote doctor is basically accessing that information and prescribing medicines for the patient. Yeah, that's it. If you anyone has any questions, so I'm more than happy to answer questions.
Okay. Um, I guess um, if the participants have any question, they can contact you, Nishant.
Yeah,
If they could.
definitely. Anything. Let's. If you have any doubts or any queries, you can always reach out to me at nishant@intellihealth.io, or you can even write to Dr. Bush or maybe Dr. Shrestha, and then we can get in touch with you guys.
Thank you, Nishant. And at the end, because we are about to end this session, I would like to uh, inform all the participants that we are going to follow up with you via email, and we'll be providing you the link to the entire recording of this session as well as the PPT that has been used today. Also, there'll be a link for the post training quiz, which will be of 10 marks. And to the participants who score 8 or more than 8 uh, marks out of 10, will be issued certificate from our side. So, that will be one link. And there'll be another link which will be for our feedback. So, we would like to hear from you. How was your experience of the training? And if you would like to share some of your experience, or if you want to add something to our knowledge, then we are more than happy to do that. And we will also be providing you the guidelines on telemedicine released by the government of India, and also our the presentation that Nishant has just shared with us, that will also be shared with you. So I would request all the participants to kindly turn on their videos, because we are not there with you. We cannot take a group photograph. So we would like to take a screenshot of with our videos on, so that it will be in our record as well, and it can also be shared with you if you would like to. So kindly turn on your videos, please, participants. We'll take a screenshot. Um, Vidya, Gilbert and Rajaji, if you could turn on your videos. Okay. Um, so smile, everyone. Thank you so much, everyone, for participating today. And we would like to hear from you. So do follow up with us with the feedback form, as well as just like Nishant mentioned, we'll be providing you our contact details um, if you want to contact us for partnership, or maybe for something that some more information that you need. So yeah, we will be providing you that too. So thank you all for joining. On this note, I'll be ending the session. So yeah, bye all. Take care.
Thank you, Shrestha.
Thank you,
Thank
Pooja.
you, everyone. Yeah.
Thank you,
Bye.
Dr. Burch.